Hello, this is UCL Uncovering Politics, and this week we're looking at the current health crisis in the UK. What is going wrong, and what should we do about it? Hello, my name is Emily McTurnan, and welcome to UCL Uncovering Politics, the podcast of the School of Public Policy and Department of Political Science at University College London. The NHS is currently in crisis. Record numbers of people are on waiting lists, there are serious staff shortages, buildings and equipment are outdated, and research indicates that patient satisfaction is at rock bottom. There does not seem to be much optimism about the UK's current health system, and indeed the NHS's once strong public support may be waning. Beyond these clinical shortcomings, we face a string of public health challenges in the UK, including persistent health inequalities and a slowing or even halted rate of increase in life expectancy. What's going wrong here? Is there a way out of the current crisis for the NHS and a way forward for public health more broadly? How much should the state do to promote our health? And can a look at the values that ought to underpin public health policy and strategies tell us how to do better? Well, to discuss this and more, I'm delighted to be joined today by two professors with recent books on precisely these questions. Albert Weale is an Emeritus Professor of Political Theory and Public Policy here in the Department of Political Science. Frequent listeners of the podcast may remember Albert's many previous podcast episodes, exploring topics from the precautionary state and the principles of collective decision-making to his career in academia to date. James Wilson is joining us for the first time today from over the road in the Department of Philosophy, where he's a Professor of Philosophy. He's also co-director of the UCL Health Humanities Centre. Welcome back, Albert, to Uncovering Politics, and welcome, James, to the podcast. It's great to have you both on the show today. Let's begin with what's going wrong. Would you both agree that we're in a moment of crisis? And what do you think is the most pressing current problem for our health system in the UK? James, do you want to kick us off?
I think it's certainly the case that the NHS and the wider health system is in crisis. And in many ways, it's a polycrisis, perhaps, because you're seeing failures within the public health system, underinvestment there. See how that's led over a period of years to increased demand within a health system and the inability to meet that demand properly. And at the same time, those working in the health system, whether doctors or nurses, feeling under pressure, then striking as a result of that. And that's leading to further challenges with waiting lists, which had already been spiraling out of control as a result of broader failures within the system. So yes, I think it's certainly the severest crisis that the health system in the UK has faced in a long time.
And Albert, anything to add to that? Or is that a fair characterisation of the situation?
No, I think that's a fair characterisation. I mean, let me just tell a little anecdote. When COVID first came along, I was teaching a course on health policy. And one of my students said, well, how do you think the UK will do in the face of COVID? And I rather optimistically said, well, I think it'll do okay because the public health system has got some very good modelers and there's some very good epidemiological understanding and so on. And I think that what COVID showed is that just how wrong I was on that. And I think what I neglected in that were the broader social trends. For example, we know that obesity is related to COVID susceptibility and so on. The broader social trends that were behind the health system. And then I think, as James has already pointed out, we've had a long-term trend. I mean, this is largely to do with budgetary policy since 2010, but not exclusively so, of trying to run the National Health Service on a very tight budget indeed, which has meant that things like bed ratios of population and doctor ratios per population are very low in an international comparison. So I think if you start to look at obesity trends, I think if you start to look at the slowing down of the increase in life expectancy, I think if you start to look at alcohol misuse, I think you can see that there are very serious problems of a health kind and not just of an NHS kind in our society.
And I guess that's an important point for this podcast as we're talking about the broader public health system. So all of these kinds of problems, as well as the immediate crisis of the NHS provision. So thank you for that, Albert.
Could I pick up on one point that Albert made? And I think this, again, was an important learning for me that came out of COVID. And that so much of the work, much of it that Albert and I had done together had been about the role of cost effectiveness analysis within the NHS, and particularly about, well, how can we measure how effective a particular intervention is, then think, well, is it good value or not? And so much of what had happened within the NHS prior to 2020 was about sort of optimization of individual pockets of activity. The idea being that, well, if we can make things individually more efficient, then somehow we'll produce the best outcome for patients that we can as a result of a system as a whole. But the one thing that COVID made very clear to everyone is that there's an important distinction between having a system that's effective or efficient given a certain level of demand, and having a system which is resilient when the profile of demand shifts. And I think that part of the deep roots of the crisis and the way in which 2020 and onwards has been an inflection point, as you've seen that the system turned out not to be resilient against the kind of problems that it needed to face during COVID, and just hasn't recovered since then. And that maybe a way for the listener to understand is, think about something like, say, running a restaurant. If you can sort of get 50 people through the restaurant within the lunch hour, then that's okay, if only sort of 30 or 40 people usually turn up. If suddenly 100 or 200 people turn up to the restaurant, then people are queuing, nobody gets served on time, people get angry when the food does arrive, it's cold, and everything breaks down in that way. And that's effectively what's happened in our health system.
So should it be less cost efficient? Is that the claim? If it had more spare capacity of a kind that, I guess in the medical context, it's highly expensive to maintain the spare beds and spare doctors that we don't really need. So there's a trade-off here, I suppose, between cost effectiveness and, I guess, Albert, what you would call a kind of precautionary principle or a precautionary state that looks ahead to possible risks and really tries to prepare against them.
I think there's a very interesting issue here about the way in which one thinks about policy across time. In our book on making health public, we quote an health advisor to the government, saying that precautionary state action is telling governments what they don't want to hear, to spend money they don't have, to guard against events that they don't think will happen. But let's just remember that as a consequence of all this cheese pairing, we ended up allocating 37 billion, right? Just let me repeat that number. A billion is a very large sum of money. 37 billion is a very large sum of money to be allocated over 2 years to a test and trace operation, which failed. So I don't think there's really any substitute for trying to think hard about how you build in precautionary and preventive procedures into the way in which you run your health system. And I mean, I would say that one of the difficulties that we've had is that governments have been anxious to balance the books year by year without thinking about what the cumulative effect of those, quotes, efficiency savings year on year really mean for the way in which the system as a whole works.
Perhaps this would be a good point to bring in. James has written a wonderful paper on what would make a good healthcare system, in which he asks the question, how are we going to deal with these wait lists that we've been left in the wake of an allocation of resources that meant that COVID was a crisis, has left us with an incredibly long wait list. So you have some thoughts about how we can go about fixing or approaching these wait lists.
What I attempted to do in the paper is almost to provide a sort of perspicuous understanding of what is the problem and what makes it different from the sorts of problems that we've thought about ethically before. And that what I take to be the central difference is that when you have things like waiting lists within a closely coupled health system, you end up with cascading scarcity. Now, there's the old adage, for the want of a nail, the shoe was lost for the want of the shoe, the horse was lost for the want of the horse, it goes on to the battle and the kingdom, and everything was lost because of the want of a nail. And we're aware, at least sort of anecdotally, in all sorts of contexts, how scarcity in one context can cascade into other places. And that seems to be exactly what's been happening in a variety of different ways. So that we see that when hospital accident emergency departments become full and you can't then get patients out of the ambulances into the accident and emergency department, then the people are waiting in hospital car parks and the response time for ambulances goes up massively. And so you see that across the system there's a variety of cascading scarcities and that each one of which can interact with others and worsen them. And so that one thing to think about is resilience and effectiveness at a system level rather than merely trying to optimize individual parts of it. And that requires maybe sort of mapping, working with stakeholders to think about sort of common and shared goals and how you negotiate those through a system, rather than trying to do anything like a cost effectiveness analysis part by part.
And another kind of cascading effect, I guess, is you have this case of cataract surgery and how when you're waiting on the list, as with many conditions, things will get worse. So sort of having a very long wait is going to have all of these extra effects for the individual as well, and how we should best handle wait lists in light of that.
Yes. So the NHS standard for waiting lists, and the assumption is within the system that people should receive a cataract surgery within 18 weeks. And we're not meeting that really anywhere in the country. And there are many parts of the country where the wait time can be over a year, perhaps even worse than that in some places. And that cataract surgery is a really problematic thing to make people wait for a year or even 2 years in some circumstances, insofar as we're aware that the condition worsens during that time. So you see in many cases that making people wait for treatment is not a neutral option. It's rather that people's health worsens the longer that they wait. And so that itself makes the kind of feedback loops that we've been thinking about worse.
I think there's some interesting work has been done by statisticians and operations research people on what happens if you cease to be fixated just on times and you start to look at the variance across average times and the peaks and troughs. And I think the easiest way of communicating this is that every student knows that they will have spent half an hour outside of somebody's door during office hours waiting to get into the appointment time. And that's because the poor tutor has had two difficult cases that they didn't anticipate before. And those have accumulated, they've cascaded down the system. Exactly the same is true of waiting in terms of access to healthcare. That is to say, you've only got to have one of these high peaks, and that really knocks on very substantially down the list. The other thing, and again, getting back to this public health perspective, which I think is so crucial here, is that we must not forget the demands on the system that arise from, to use the jargon, the social determinants of health. I mean, that is to say, people's lifestyle and other factors that cause them to make demands on the system. So I was very interested, for example, to hear Mark Drakeford standing down as First Minister of Wales. I think he's a very thoughtful politician, actually, pointing out that part of the difficulty that the Welsh healthcare system had in meeting its A&E targets was the burden that it faced in dealing with just simply the problem of drunkenness. So we have to think not just of the health system itself and the way in which it's processing those demands, but we have to locate that health system in the broader social system that's actually generating and responsible for generating those demands.
And your recent book, Albert, definitely emphasised the importance of public health, I think perhaps over a narrow focus on clinical care. There's a quote in the book of the WHO Health Equity Status Report calculated that 90% of health inequalities across different socioeconomic groups are explained by social and economic conditions like poor housing and working conditions, and only 10% is about access to healthcare. So do you think we're focusing perhaps too much and putting too many of our resources in our health budget into clinical care, into what's going on in the NHS, and too little into public health?
I mean, this is a very interesting and difficult issue, I think, and I think both James and I have sort of thought about this and written about this, which is one way of thinking about it is the so-called choice between statistical lives on the one hand and people in current need, the rescue imperative on the other. And I think politically that is very difficult to deal with because quite clearly in electoral terms and in political terms, and quite rightly I think in healthcare terms, waiting lists and current demands naturally preoccupy people's attention. On the other hand, unless we were to step back and to think about how to make the broader set of interventions that can reduce those demands on the medical care system. I mean, we should not confuse medical care and health policy. Unless we can step back and think about what is sometimes called health in all policies. That is to say, you're thinking about transport, you're thinking about air pollution, you're thinking about food policy and competition policy and so on. You're thinking about all those dimensions of the social and economic and political determinants of health. Then I think you're inevitably confronting your medical care system with some very considerable problems.
And one of the ones you add in the book is, which I hadn't heard before, I'm sure there's other work on it, but the idea of a commercial determinant of health,
yes,
which I thought was a fascinating thought to add, that actually there's lots of things that companies and organisations are doing that is damaging for our health, from ultra-processed food to situations with air pollution and not having the right kind of fuel in our cars and so on. And so I thought that was a very interesting part to add to the picture, which suggests a great deal of state control in your picture, I think, Albert.
Yes, but also remember, I think that on the commercial side, of course, there are commercial forces on the other side. I mean, so to speak, manufacturers of sports equipment have an interest in good health, for example. Manufacturers of clean vehicles have an interest in good health. So I think the task of the state is to somehow try and reinforce, so to speak, those commercial imperatives that are beneficial for health and reduce those commercial imperatives that are bad for health.
I think I would agree with nearly all of that. I slightly disagree with Albert on the extent to which they're commercial determinants of health, where it's in the good interest of companies to do things that will make people's health better. Because I think one of the challenges that even where there are cases like, for example, manufacturers of sports equipment, their business model is improved very much by people buying more of their products. Even within that framework, you can see that, well, say when Nike builds its Runkeeper app, they're attempting to capture attention, they're attempting to capture data in order to sell things back to people. And so that whilst it may be that the activity they try and sell is much healthier than, say, that fast food companies, there's still something sort of potentially ethically problematic about the way that data is captured, about the way in which doing something like, say, running, which one could do, in a much cheaper pair of shoes or in a non-competitive way, then gets turned into something which kind of becomes much more elitist and commercial.
I think there's a really interesting question here about population health and data sharing and data linkage. And I have to say, I've tried to think about this a little bit myself in the past, and I've not come to any clear conclusions. But it would be extremely interesting to have data, for example, on unemployment and ill health, to be able to link up those data sources. It would really be very interesting indeed to have data on purchasing behaviour and health and how that then relates to income and so on. Now, of course, all the difficulties here are about who gets control of this data and what they make of this data and whether they're using it for good purposes or bad purposes. But anybody who's ever thought about, well, what is the best type of food to eat or whatever is going to be interested in the data. And I think any responsible government to be interested in how far, for example, its taxation policy or its industrial location policy or whatever other policies there might be are likely to have effects on health.
Let's take a step back to the kind of foundational questions. So we've got into the details of some of the crises, some of the issues that it's throwing up into the healthcare system, some of the questions of what public health policy might include, such as things like how we're going to deal with these commercial interests that might be driving public health in the wrong direction. Let's have a think just for a second about why the state should be so central in the promotion of health. So I suspect that perhaps some listeners are thinking, surely the state isn't the one that should be deciding what we should eat or how much exercise to take or, having the state track our data to figure out if we're making the right kind of buying choices and how it can nudge us to make better buying choices. So perhaps we could turn to what justifies the state pursuing public health. So perhaps we could start with James. So in your book, you defend a right to public health and accompanying duties of the state. Could you tell us a bit about the idea there?
I certainly can. So I might step back to begin to frame the issue a little bit. The most important question to think about the individual and the state when it comes to health and public health is that who bears responsibility for reducing risks? So there's certain things that you can do as a pedestrian to reduce your risk. You could go out wearing a crash helmet, pads all over you, just in case people are driving dangerously. But obviously it would be extremely inconvenient to have to wear large amounts of padding and be extraordinarily vigilant every time you left the house. And so you might well think it's more reasonable to try to control that risk in other sorts of ways, for example, by ensuring that drivers have to take a test before they're able to drive, that people aren't going to be driving drunk, that there's street lighting, and so on. And so that a lot of it's really about how we can reasonably control risks to ourselves. And a lot of the risks that we can face just in going about our day-to-day lives and being in public space are things that we're not in a very good position to control as individuals, whether questions around air pollution, if that comes from factories or from diesel cars, to threats to our body. So we're not in a position to control those things for ourselves, and that most people are going to think that a decent society is one in which risks to health and life and limb are minimised insofar as possible. Now, some of these debates about the individuals and society and how to balance them when it comes to protection and promotion of health have been going on for a very long time. And that the classical thing to do has been to suggest that there's such a thing as the common good that the state ought to protect and promote. And because of the importance of the common good, each individual's rights can be curtailed in various sorts of ways. And the one thing I noticed about 10, 15 years ago is those sorts of arguments stopped having the purchase they previously had to, maybe as people absorbed more of ideas from neoliberalism. And so that one of the new moves I attempt to make in my book, The Philosophy for Public Health and Public Policy, is to suggest that rather than framing it in terms of the common good, what we should argue for instead is that there's a right to public health. That's to say that if the state doesn't take easy, simple, cost-effective measures that it could do to protect the health of all, then your rights as an individual citizen have been violated. And I think this is very plausibly what's happened within the UK over the last 10, 15 years as government has consistently failed to take action on air quality, where you notice that at least 30,000 people a year have been dying as a result of air pollution. The government's failed to take action even after a number of different court cases. In that case, I think it's quite reasonable as an individual to think that there are international standards here that the government ought to comply with. The government has not taken steps to comply with those standards. As a result of that, risks to me as an individual are far higher than they otherwise would be. That the government has effectively imposed a risk on me that was unfair for the government to impose on me. And in so doing, the government has fallen short. It's been neglectful in a duty to promote and to protect public health, and therefore my right to public health has been violated.
There's something very interesting going on here, because it seems like this way of formulating it looks extremely promising, but it does require us thinking about the government failing to do something that minimises our risk, where a lot of these interventions look like they're trampling over someone's rights to benefit someone else. So even taking the air pollution case, right? Think of all of the protests around the ultra low emissions zone in London, where people say, well, I don't have the freedom to drive my car without having to pay now, for the benefit of those who, I guess, live in the area and then have less air pollution in their area. So your way of framing it makes sense when it's a kind of claim against the government. The government ought to have acted and it hasn't, and now I'm ill. But does it slightly obscure the fact that to promote some people's health, we're sometimes having to restrict the liberties of others, even if it's just the freedom to drive your polluting car through a highly dense neighbourhood?
I think I certainly would agree that when governments take action to regulate and thus reduce health threats in the environment, yes, often businesses may be regulated, often the behaviour of individuals will be regulated. And that one analogy which I think is quite helpful to draw is to the right to security. Now, pretty much everyone thinks that it's a core part of what governments can and should do is to ensure the security of every individual. And that with that comes some things that are just a bit annoying, so that probably sort of all of us are aware that whenever you try and take a flight, then there's all sorts of checks that need to be undergone. People trying to take your water off you, and they force you to take out your shoes, be x-rayed and so on. Your rights are infringed in various sorts of ways in the interest of pursuing security as a whole. I think exactly the same kind of argument can be brought to bear on why it is legitimate to interfere with the behaviour of those who might want to drive a highly polluting car. The goal to be attained, saving hundreds, if not thousands, of lives through improved air quality, is an important one that everybody can and should get behind, and that will require some people's behaviour being regulated or shifted, or maybe paying a few pounds to drive into central London. I think that that's a price worth paying, and that there's no liberty to impose risks on other people, or at least it's not a liberty that we should be strongly defending.
Now, am I right to think that in your book, where you propose a new social contract for public health, that it's a bit more like the old system that James was criticising, the sort of common good? It feels much less individualistic, perhaps your defence of it. So while James is saying, well, look, as an individual, you have a right to public health and the government has wronged you, it seems to me that on your picture, you're less concerned with the individual benefits and rights and much more oriented towards the social costs. So you say things, in the book says things like, if individuals choose to eat junk food and drink too much, they will inevitably place extra demand on the health service. You describe those who refuse vaccinations as walking health hazards for others. And you seem to, so I think there is a bit more of a collective picture going on about what public health is about. It's about securing this common good of public health. Is that correct, or am I mischaracterizing?
No, I think that's a very fair characterization. I think the social contract perspective is one in which I think really the central proposition of which is that there is no. It's only a seeming paradox to say that in order to secure individual interests and individual fulfillment, we need to have strong collective organisation. I mean, that I think is the key. In this book with Peter Littlejohns and David Hunter and Jacqueline Johnson and Taslima Khartoum, we distinguish between what we call vulgar individualism and what we call social individualism. So vulgar individualism is really characterised by the belief that government is best which does least. And you can see that view playing out in criticisms of health policy in terms of the nanny state. We shouldn't be controlling what people drink, or we shouldn't be thinking about their diet, and so on. We criticise that vulgar individualism. And I think one of the reasons why we criticise it is that if that view were carried through consistently, there are lots of things which are entirely uncontroversial in our society which would have to go. For example, product safety. We regulate things like the inflammability of furniture and so on. So if you take a completely consistent vulgar individualist view, you would really operate on the principle of let the buyer beware. And we don't operate on that principle. And I don't think there's any reason why we should operate on that principle in healthcare either. I think it's also worth noting, we don't say this in the book, but it sort of occurred to me thinking about it subsequently, that the part of the argument against public health, the vulgar individualists, has been that this puts the state in a coercive position. But if you think about what public health people say, for example, about drug misuse, a very standard line in the public health profession is to say we should treat drug misuse as a harm prevention issue, not as a criminalisation issue. It's less coercive in that sense than is some standard views about drugs misuse. So we offer this view that we call social individualism. And now that may seem a contradiction in terms, but I think it goes back to this point that in a society where individuals are interdependent, where the actions of a person or group of persons affect another group of persons, we need to think about collectively how to regulate those interactions for the good of each. Not for the good of all, but for the good of each. That's what the social contract will deliver, ideally. And so what you're trying to do in social individualism is to think about what a charter of rights and freedoms would be if it regulated the interests of each in a fair way. That's what that's about. And the social contract, I think, is a useful way of trying to think about how we might together collectively about what those fair ways of balancing off rights and duties and interests might be. It's very important in this context, by the way. This is you can say this is an ideological position, and indeed I think it is an ideological position. It's not just a philosophical position. I think it is also an ideological position. But I don't think it's an ideological position that is partisan. So one of the things that we do in the book is that we cite, I think, a much neglected book by W.H. Greenleaf on the British political tradition, in which he identifies these collective elements in all the major political traditions. I mean, it's true of conservative thinkers as it is of liberal thinkers and it is of socialist thinkers. So I think that what's going on here gets back to this central insight of social contract theory, that when you can't just leave individuals and the collective consequences of individual action just to lie where it falls, so to speak, you need to be able to think about regulating that such that you get a fair balance of interests among the members of society.
And James, in your book, you're keen to steer between the nanny state, which it sounds like Albert's just offered us a nice defence of the nanny state, perhaps, as some people would see that. But you're interested in steering between the nanny state and what you call a neglectful state. So I think you're looking for somewhere in the middle. Is that right? So I wondered if you could tell us a bit about what the neglectful state looks like, and how you might be short of a nannying state. Perhaps, as Albert has defended, perhaps Albert will resist the characterisation of his defence as a nannying state. But certainly Albert's defence is of a very involved state in terms of the public health outcomes of the various individual choices that we make.
Yeah, I guess the phrase "the neglectful state" it came from me sort of in reflecting on the aftermath of the Grenfell fire. Just a realization that why it was that so many lives have been lost on that particular night, and you can see that also the gaps within people's thinking about fire safety, the way in which the materials have been tested, the fact that residents had attempted to raise the alarm and people knew that all sorts of things were dangerous about the block, nothing was done. And it struck me there's a pattern there. You can see in lots of cases where things go very badly wrong within public health that there were easy things that could have been done which would have reduced risk to populations, and that if those things are easy to do, they can be cost effective to be done, but they're just for one reason or another not done, then I think that you can frame what happens as a result of it as deaths by neglect, and that when that happens, I would suggest that the state, whether central or local government, is not being fulfilling its duty properly. So I think that something like Grenfell would be an obvious example of that. And so I think that one thing that Grenfell allowed most people to grasp is the idea that, as it were, that government is not doing its job properly if it just allows harm to occur on such a scale when it could have been. And I think the interesting and hard question is, well, how do you move from the cases like Grenfell where everybody is going to agree about those to cases where you realise they become controversial? Where do we draw the line between those? And one thing I find interesting and tricky to tease through sometimes when I talk to students about them is that we discuss something like, say, Mill's harm principle, the idea that the state shouldn't legislate unless to prevent harm for others, and all the students nod along, think, yeah, that's great. And I say, well, how about seatbelts? I think that we can and we do quite often intervene just in order to make people's lives better, sometimes without their permission. And I think that can be a good thing. And in fact, utter failure to do that is to fall into the trap of the neglectful state. I think that perhaps where I differ slightly from Albert is that I think I'm much more... I think I hear the sounds much more, and I'm much more persuaded by the worries that people have who just find it annoying to be told what to do all the time. And so that my ideal for public health is public health to be able to reduce risks from the environment and make people's lives better, but often in a slightly unobtrusive way that they don't notice what's being done. So that maybe the example that Albert gave of the product safety is a brilliant one. So that it's probably something that absolutely nobody thinks about when they buy a kettle, or that they just take for granted that if I buy a kettle, then it'll work and it won't blow up when I plug it in. And you can see that the failure to ensure product safety, as we're seeing with e-bike batteries at the moment, is a very bad thing. What I try to argue for in my book is that often it's better for the state to attempt to intervene upstream by regulating what manufacturers do. And that often by intervening upstream, that the state can, as it were, ensure that people are only presented with a set of choices, each of which is safe enough so that it isn't annoying for the individual to feel that either they have to be ultra vigilant to work out which out of these toys is actually safe for my child, or indeed to be sort of in their face about it. So by intervening upstream, I think that often you can get all the benefits of pursuit of the common good, and you can avoid the nanny state whilst still pursuing a good public health agenda.
So a nanny state for manufacturers and so on, not much for the individual. Is that the... So I, as an individual, go about my daily life uninterfered with by the state because it's done all the interfering. That's perfect.
I think, Emily, I'm going to resist your thought that my position is that of the endorsing the nanny state, so to speak. I mean, I think that what I would say is that I think that the role of the state is to do something that there can be some sort of social agreement about. I mean, it doesn't have to be complete unanimity, but it has to be a sort of serious social agreement about what a responsible way is of governing the interactions of society. So the state, from this point of view, so to speak, is the expression of what we would think if we thought responsibly about matters. So, we don't want children to be able to poke toys in their eyes and so on. So I think it's not so much the nanny state. I mean, it's a state that, so to speak, captures where the centre of gravity is. Now, I think the interesting question from a sort of policy point of view, as distinct from the point of view of philosophical principle, is how you do that. And there, I think, so if we go back, for example, to the ultra-low emission zones and so on, there questions about sequencing and timing become very important. So it's no use saying to people you just can't drive because we're protecting air pollution unless you've already got in place some alternative form of transport. So the sequencing there becomes very important. The speed at which you do things becomes very important because people are invested, for example, in their energy systems or their transport systems or whatever, and you can't just withdraw that. So I would say that these practical policy questions then become very complex about how you think through questions of sequencing, the precise way in which you do it. I think I would slightly resist the thought everything can be done upstream. Nice if you can do it upstream. I mean, obviously ideal because that then shapes the environment and people don't feel, I get terribly annoyed when I have to take my shoes off at the airport, and I think, well, this shoe bomber, has got a lot to answer for and so on. But I think there are occasions when people will feel the burden of what is a responsible decision. Now, lots of people are prepared to be irresponsible. I mean, let's not forget that we had a Secretary of State Health not too long ago, Theresa Coffey, who was quite happy to say in public that she shared her antibiotics with her friends. Well, I mean, that is an utterly irresponsible thing to do. I think at that point there needs to be some pretty firm regulation about individual behaviour.
James, I don't know if you wanted to come in or defend your upstream or other.
Yeah. So I suspect that Albert and I agree about nearly all of this, but maybe we think about it in slightly different terms. So that I think for me a really important thought is that libertarians are not wrong that liberty and autonomy are important. I think they are. It's really important. It's really important that people get to live the kind of life that they want to, and restrictions can hamper people in doing that. But that I think often libertarians sort of overclaim that almost they start from the idea that sort of individuals are sacrosanct and we shouldn't interfere with individuals, and they can also transplant some of those ideas so that they think of corporations as more like individuals. Somehow we shouldn't interfere with the liberty of corporations as well. And so that, from my perspective, I think I'm quite sort of persuaded by some of the points about the importance of individual liberty and autonomy, but I just don't think they follow. They don't. You can't transfer them to corporations. So nanny state for corporations, but not for individuals on that account.
Which is a fantastic slogan. Well, on that note, and with having given our listeners a sense of the real richness of these books, and I'll talk a bit in a moment about what the books are called and where you can find them, but having given a sense of the real richness and background to these important ways of rethinking how we're approaching public health, I wonder if I could ask you both to really distill your ideas, and if you like, since the general election is on the horizon, if you were going to make one pitch to the incoming government, whatever that may be, what's the first thing they should do, or that they should do to deal with public health in the UK? If you were going to push just one single policy of reform, what would you pick? Maybe James, do you want to kick us off?
Can I have two?
Yes, you can have two.
So I think there's a conceptual point that I would hope that everyone can and should grasp. As somebody who reads The Guardian every day, I find it sort of baffling that nearly every day The Guardian posts an article with a headline basically it's the same story every single day, which is people who are badly off in this respect also have worse health. And that I find it odd and perplexing that this is still presented as news, and that really I think we should start all our policy analysis from just a realization that the social determinants of health matter, and that they're interlinked, and so that we should not be surprised when people whose lives are are vulnerable in various aspects also have worse health. I think as a result of that, you need to think, well, how much do we actually care as a society about reducing health inequalities? And I hope the answer is a lot, but that if we really do care a lot, then we have to put our money where our mouth is and realize that, well, you can't make systemic changes to health inequalities without looking at the broader systems within health, within which expanding health inequalities are embedded. So, yeah, one big idea is, well, think of the systems, think of the social determinants of health. And one more practical problem, or one more practical suggestion would be just to undo a lot of the harm that came with the abolition of public health. England splitting it apart into two different elements provides the UK with a body which has overall control and responsibility for public health, which brings together health protection and health promotion, which doesn't split apart interest in health inequalities from that in infectious diseases and threats to health more broadly.
Fantastic. And Albert, what would be your policy proposal to the income?
Well, I just want to pick up on what James has just said. I mean, I agree entirely. I mean that if you start from the idea of the social determinants of health, in a way, that is not something that a government can address in the totality immediately. I mean, indeed, it's a challenge for decades of government. But I think the starting point would be to, as James suggests, to rejoin together those parts of the public health system which have been concerned with health protection, such things as protection from infectious diseases or extreme weather events or whatever, with that part of the system which is concerned with health improvement to do with diet and lifestyle and so on, which has been drastically lost. I think one should not underestimate the changes that were brought in. I mean, let's remember the Public Health England was abolished in the middle of a pandemic. It was about the worst time that you would engage in a government reorganisation. On the question of the challenges of the social determinants of health, and I would assume that any incoming government of any persuasion is going to be faced with some enormous difficulties, and it's certainly going to be faced with difficulties about not being able to spend money that it cannot finance properly. I think the right strategy there is to try and find some predominantly regulatory policies which act, if you like, as a down payment on the promise of trying to deal with the public health challenges that arise from social determinants. And there, my suggestion would be something like minimum unit pricing of alcohol, which has been adopted in Scotland, but not in the rest of the UK. Not because I think that's necessarily the effective public health measure, but I think it's something that you could do relatively quickly. There's good evidence that it has beneficial effects. And as I say, I think it would operate as a down payment. On questions about trying to reduce air pollution, I mean, that is obviously a much longer-term task, as is the question of diet. Again, early on, you might be able to do something with a sugar tax, for example, but again, you'd have to think about the politics of that. But I think the strategy is, if you like, to be aware of James's big picture, but to try and come up with something concrete and focused that takes you in the direction of dealing with that big picture.
Thank you, Albert and James, for that fantastic conversation about healthcare, public health and health inequalities. We've been discussing two fantastic books and an article by today's guests. So there's Albert's book, Making Health Public, a manifesto for a new social contract, co-written with Peter Littlejohns, David Hunter, Jacqueline Johnson and Tolsima Cartoon, and published earlier this year by Bristol University Press. And James's book, Philosophy for Public Health and Public Policy, Beyond the Neglectful State, and his article, What Makes a Health System Good? From Cost-Effectiveness Analysis to Ethical Improvement in Health Systems, published in Medicine, Healthcare and Philosophy last year. Full details, as ever, are in the show notes for the episode. This has been our final episode for the term. We'll be taking a break over the next few weeks for the Easter holidays, but we'll be back in April for another series exploring the very latest in research in political science and political philosophy. As ever, to make sure you don't miss out on those future episodes of UCL Uncovering Politics, all you need to do is subscribe. You can do so on Apple, Google Podcasts, or whatever podcast provider you use. And while you're there, we'd love it if you would take a moment of time to rate or review us too. I'm Emily McTurnan. This episode was researched by Alice Hart and produced by Eleanor Kingwell-Banham. Our theme music is written and performed by John Mann. This has been UCL Uncovering Politics. Thank you for listening.